travel isn't just about destinations. It's about the people you meet, the cultures you immerse yourself in, the stories you carry home. I'm Relebogile Mabocha, and on my travel feature, I take you on a journey beyond the guidebook. Each week, I connect with fellow travelers, insiders, and storytellers to bring you the heart of every place. Whether it's a hidden gem right here in South Africa or a dream destination abroad. Join me as we travel through conversations, memories, and inspiration. Listen wherever you get your podcasts.
702
Health and Wellness.
All right, we get into our health and wellness feature now, where we're talking about how to deal with fertility challenges. June marks World Infertility Awareness Month, a time to bring visibility to this global health issue that affects, I think, 1 in 6 adults, according to the World Health Organization. And yet here in South Africa and around the world, infertility remains shrouded in silence. There's still lots of stigma and misinformation. So it's important to actually talk about what is fact, what is fiction. And it's important to also note that infertility is not just a women's issue. Male infertility factors, in fact, account for about 40% or so of cases, and yet they often remain overlooked. Have you struggled with infertility before? How have you approached the challenges of infertility? I'd like you to share your experiences with us on 011-883-0702 or send a WhatsApp on 072-702-1702. Dr. Anthony Picton is a fertility specialist joining us on the line. Thank you for making time, Dr. Picton. Good morning.
Good morning. Thanks for having me on your show.
I want us to start off by perhaps looking at how infertility is medically defined, because sometimes there are couples who are planning a family, they've been trying, and they're quick to diagnose themselves even when there hasn't really been an official diagnosis, because they've tried a couple of times and really nothing has happened. So how is infertility medically defined?
Well, the textbook will say that infertility is defined when a couple has been trying to conceive for longer than 12 months unsuccessfully with no sign of conception, meaning no miscarriages, no ectopic pregnancies, and no ongoing pregnancies after a 12-month period. And this is a very dated view of infertility, because we understand that the world has moved from heterosexual couples to same-sex couples and to single females looking to conceive and single males looking to conceive using ART. So it also makes no provision for age. If you are above the age of 36, that 12-month period should be much shorter. It should be 6 months. So, if you're 20 and you haven't fallen pregnant within 6 months, well, then to go to a year is fine. But if you're 42, you shouldn't be waiting for a year before you seek assistance.
Yeah, and speaking of age, for women, that seems to be a big factor. It's often mentioned as a major factor. So at what point then does fertility typically begins to decline?
Well, without a doubt, we see, if we check the genetic makeup of embryos, which is what we do with a lot of IVF cycles, about 85% of IVF these days is done with genetically tested embryos here at VitaLab, meaning we know the genetic makeup of that embryo prior to usage. And so we extrapolate that data for the broad public out there. And there's a genetic sweet spot between about 25 to 32 where the embryo quality is actually quite good. Above the age of 32, we see an increasing abnormality rate within the embryos. So just to give you some ideas, if we were testing the embryos these are fertilized eggs which have been grown in the laboratory for 5 days, the same as it would be naturally growing in the fallopian tube. In women between 36 and 37, about 66% of those embryos, in other words, 2/3, will test abnormal. By the time a woman gets to 42, about 90% will test abnormal. So in other words, 1 out of 10 versus 1 out of 3. And at 44, that has gone to 1 out of 20 embryos tested will be genetically normal. And this is something we have no insight into. It's not covered in biology. It's certainly not covered at schools or at varsity. And so there's this lack of knowledge. And the first time people actually are aware of the impact of their age is when they approach us in their 40s looking to conceive for the first time. And that's unfortunate, really.
And for men?
Well, reproductive fitness affects men slightly differently. And the reason is the physiology. So men produce sperm on a daily basis from the time of puberty till the time of death. And that sperm production line is about 74 days long. So call it 3 months. So whether you're 16 or 96, the sperm is 3 months old, and hence men can father children even into their 80s. Of course, there is a consequence to male aging, and that is that men above 50, their partners, although they will conceive and have higher miscarriage rates than the partners of men below 50. So it's not a complete free card. There is increased sperm DNA fragmentation, which affects the sperm quality. But, there's a big misnomer out there. There's definitely a disproportionate burden of responsibility for fertility placed on females.
Yeah.
So if a couple's not conceiving, very often the eyes of the family and the extended family are on the female partner. And men seem to feel that if they ejaculate and they can see something, then that volume must equal sperm, which of course 80% of that is actually from the prostate, the seminal vesicles, the bulbourethral gland. It's got nothing to do with sperm. So they misinterpret what they're seeing as being a sign of fertility. Meanwhile, you could have azoospermia and still have an ejaculate. So there's this misnomer out there that a lot of men are reluctant to be tested because they say, well, I know that I'm fine. Using sort of like a visual cue, which of course has got nothing to do with the sperm function.
Yeah. So would you advise then that there must be some assessment done, so get checked up, and at what age, at what point should that be so that it's not too late? Should there be anything that's picked up?
Well, look, in couples below the age of, let's say, female age of below 35, if you've gotten to 12 months of unprotected intercourse and there's been no sign of conception, I think it's reasonable then for both partners to be assessed at a fertility unit, where they would have a look at the sperm quality, they would have a look at whether the fallopian tubes are open or not, whether they're patent, look at the uterine cavity and also the uterine walls to assess whether that uterus is intact and fit for a pregnancy. You really want to be finding an answer, because if we look statistically, the chance of conceiving in the first 6 months per month is about 20% per month. Beyond the first 6 months, so from 6 to 12 months, that has dropped to 10% per month. And for couples that are saying, well, we don't want to push this, we're going to try spontaneously, from 12 to 18 months, that has dropped to 4% per month. So in other words, you've got a 96% chance of not conceiving every month when you've been trying for a year already. And that's where that cutoff comes from, because by 1 year, 85% of couples have fallen pregnant spontaneously. So it's only 15% that are still trying. And for women above the age of 36, that should come much sooner. You shouldn't be waiting a year, 6 months tops, because age is playing a big factor.
Yeah. Well, what are some of the common medical conditions? You've mentioned a few on the female part, those that contribute to infertility, and I'm hoping you can touch on for men as well.
Oh, for sure. So, look, unfortunately, there is a disproportionate burden of disease on women because they are the supplier of the eggs and they are the supplier of the uterus, which is housing the pregnancy. So things like fibroids, structural abnormalities of the uterus, fibroids, polyps, which are growths within the lining of the uterus, endometriosis and adenomyosis, which are inflammatory conditions within the muscle wall of the uterus and within the pelvis. Those can all affect things from the female side. And, of course, endocrine abnormalities, in other words, thyroid dysfunction, polycystic ovaries, and ovulation can all affect it. On the male side, we see that about 40% of the men that we test are contributing to the infertility. So it's far higher than what the general public is aware of. Certainly we see that the lifestyle that we're living is playing a part. There's no doubt that lifestyle stresses, overweight, smoking, drinking, all contribute and to a change in sperm parameters. And I think the other thing that we're seeing is a pandemic of men that have been placed on testosterone supplements. Guys will go to the GP, say, look, I'm feeling tired. They'll pull a random testosterone and be told, look, your testosterone's low, and they'll be put on some form of testosterone treatment or depot-testosterone, not being aware of the fact that when you take an external type of testosterone, it's interpreted by the brain as an overproduction by the testicle, and it actually switches off any further stimulation of the testicles. So a lot of those gentlemen will come in, and we'll be able to tell them, look, your testosterone is extremely high, but your own sperm production has been actually stopped, and your own testicular production of testosterone has also been turned off, and we need a washout period to let this recover.
Yeah.
And of course, anabolic steroids is even worse because that's a stronger form of male hormone. The guys that are in the gym pushing all the plates, they're looking to bulk up, and those steroids have the same kind of effect.
Oh, I see. All right, it's 11 minutes now before 12 o'clock. When we come back, we'll go straight to the calls and WhatsApps.
Travel isn't just about destinations. It's about the people you meet, the cultures you immerse yourself in, the stories you carry home. I'm Relebogile Mabocha, and on my travel feature, I take you on a journey beyond the guidebook. Each week, I connect with fellow travelers, insiders, and storytellers to bring you the heart of every place. Whether it's a hidden gem right here in South Africa or a dream destination abroad. Join me as we travel through conversations, memories, and inspiration. Listen wherever you get your podcasts.
702 Health and Wellness.
9 minutes before 12 o'clock, we're discussing on our health and wellness feature this morning how to deal with fertility challenges. As we've indicated earlier, June marks World Infertility Awareness Month, and it's a time to bring visibility to this global health issue that affects so many people out there. Dr. Anthony Picton is a fertility specialist joining us. Let's start with your WhatsApp voice note.
Good morning, Clement. I'd like to stay anonymous. Clement, I've had 3 relationships. In all 3 different relationships, obviously not at the same time, all 3 of them, we've had a miscarriage. The last one really took a toll on me because we were trying, but my partner had a miscarriage. It was so difficult. It tore us apart. It ended the relationship. I knew that she had some issues, but I'm beginning to feel that maybe it's me. I am so scared to go and seek help and find out if I'm really the issue.
Thank you for sending that, and I'm sorry to hear that. I'll get Dr. Picton to respond to that. Tato, you are calling us from Kempton Park. Good morning.
Hi, Clement, and hi to the doctor.
Sure.
I just have one question. So I've been trying with my partner for over 12 months. Yeah, but from adolescence, she had an op with the fibroids and cysts. I'm not quite clued up there, but she did that operation of the cyst. And then now she's 28. And I'm 34. So we've been trying for over 12 months. But nothing seems to be happening. So I would like some advice from the doc. Thanks, eh?
Have you guys consulted yet, Tato?
No, not as yet. As yet. But also in between she has sort of those irregular periods. She has sometimes irregular periods. Maybe she'd go for like probably 2-3 months for the periods, and then come back, go on a period for probably, let's say, a week and a half or 2 weeks. Yeah.
Okay. Tato, thank you for calling in. Thanks for your question. Dr. Picton?
So, let's start with the second question first, just because it's fresh. If you've got irregular menstrual cycles, it's very often an indication that ovulation is not taking place. So the menstrual cycle is, if you like, a sign of ovulation. So regular cycles tend to be regular ovulation. Irregular cycles or skipped cycles are often cycles where there's an ovulation taking place. So that's the first place to start. It's important to also realize that fibroids are often disease which recurs. So especially someone that's had an adolescent surgery for fibroids, which is quite early in their reproductive life, they may find that now 5 or 10 years later, If you did an ultrasound of their uterus, you may find new fibroids there. So very often when you have a myomectomy, which is when you remove the fibroids, you don't create a cure for life. You create a window of opportunity. And that window of opportunity will be a different length or different size for different patients. It may be 4 years for one woman. It may be, longer for someone else. But if you're then out of that window again, you may have a look and find, to your surprise, there's recurrent disease. So without a doubt, if it's, at 28, that's a great female age, good egg quality, but you want to have regular cycles and you want to be sure that there's nothing standing in the way. So you want to know, is the cavity normal? Is the uterus normal? Are the tubes, both fallopian tubes, open? Can we ensure ovulation is taking place? And how does my sperm look? And that's the way I would start looking at that. Because what you don't want to do is waste another year and all the frustration that goes with that. There's always three costs to everything. There's the financial cost, but then there's the time cost and the emotions that go with that. And we tend to discard the time and the emotions, but in the end, they're probably the most damaging of all the costs. You know what I mean? So you want to at least know that it's possible to fall pregnant. There aren't fibroids which are compromising the uterus, and there is an open pathway, and that the sperm is able to be functional. Regarding our first voice note, recurrent miscarriage. In that sense, we define recurrent miscarriage as 3 consecutive losses in a single patient, which is normally going to be a single woman.
Okay.
But with that history of having had 3 different partners, all with miscarriages, the question obviously arises: what's happening with the sperm? So there's 2 tests off the top of my head which I would automatically want to do. I would want to have a look at the sperm, and there's a thing called sperm DNA fragmentation, SDF, which we've just alluded to earlier, which can give us some indication as to what is the genetic makeup of that sperm looking like. Is it a high DNA fragmentation? And then one can look at lifestyle modification to improve on it. And the second thing is you can be a carrier of what is known as a balanced translocation. In other words, you can have a structural rearrangement of your chromosomes. We all have 46 chromosomes arranged in 23 pairs. If a small piece of one chromosome has broken off and is sitting on top of another chromosome, it would mean that overall all the genetic material is still there.
Okay.
But when you produce sperm in the case of men or eggs in the case of women, those chromosomes may separate unevenly, leading to unbalancing within the gametes.
So it's better for him to go get checked out.
Definitely, because then at least, you don't want to walk around with unnecessary guilt.
Absolutely.
And, if you can exclude that, then fair enough.
Yeah. Dr. Anthony Picton, fertility specialist, thank you so much for making time for us.